Hello everyone. Let's start this giant presentation. It is probably going to be, I haven't done this yet, so at least 2 parts, maybe 3. So please make sure you listen to all 3 or all 2 parts. This has got a ton of information. This is all jam-packed. I guess after starting this and like redoing this presentation for this year and kind of updating it, I was like, maybe I should just make this in the future 3 different presentations instead of having one giant presentation that's like 130 slides. But yeah, I thought of that too late. But anyways, just trying to get this. just slap my microphone there out of my disgust with myself. Sorry about that. Hopefully it didn't hurt your eyes or anything. I mean, ears. It hurts your ears, not your eyes. Man, I'm rough start. Okay, anyways, sorry guys, bear with me here. Okay, so yeah, it's gonna be multiple parts. Sorry about that, but we'll just chop it up here with integrity, and let's get into it. So this is why you can probably guess why it's such a giant presentation. We're gonna be talking about the antipsychotics, pretty in-depth, antidepressants, also in pretty detail. Mood stabilizers, not as much. This is kind of a lighter section. And ADHD, the attention deficit hyperactivity disorder, also is going to be not as big of a section. So the bulk of it's going to come from antipsychotic antidepressants. All 4 sections are important for testing purposes. Please do not neglect the mood stabilizers nor ADHD. Students in the past, we used to not have pharmacology 3, and so all this psychiatric stuff, all this was actually, I jammed it into neurology in the fall semester. So it was an insane module as far as the amount of drugs the students had to study and everything. So it's pretty crazy. And I think that's why they would neglected the mood stabilizer and the ADHD, but I'm not sure exactly why. They mainly focus on the antipsychotics and antidepressants, which is good. I mean, there's a ton of drugs in those sections and everything, and you guys please focus on those, and definitely look out for when I say things are testable or test material, or heads up for testing purposes, etc. So let's start off first with the antipsychotics. The other quick note too that I just remembered, and that's why I was stalling, is because I did want to note that the DSM-5 is what you guys will be responsible for your psych module and for your board exams, as far as I know. At least that's the last I was told. And so please refer to DSM-5 as far as terminology and most current diagnosis and everything. So for my course, you don't have to worry about diagnosis. It's just the use of the drugs, but just make sure that those, when you're studying for your boards, that you will be using the DSM criteria for diagnosing. So anyways, antipsychotics, historically they're referred to as neuroleptic drugs. You don't really hear that too much, every once in a while. So I think I've mentioned to you guys before, I worked at a psych hospital in San Antonio for a year, and every once in a while there was a physician or a nurse that would refer to them as neuroleptics. But for the most part, nowadays, antipsychotic is usually what you will hear people refer to them as. They are useful for schizophrenia as far as other psychotic disorders, which again you'll be learning more in detail in. But some examples: paranoia, hallucinations, both auditory and visual, delusions, depression, poor socialization, etc. With the antipsychotics too, just a little bit of terminology. You will have the newer ones are considered, or rather they're called atypical antipsychotics, and I'll show you which ones those are. And then your older ones are considered conventional or typical antipsychotics. So just kind of depends. It sounds to me kind of sounds like a joke, like typical antipsychotic, but it's typical and atypical. So older and newer. So definitely, and you'll notice throughout my presentation I refer to them as typical or atypical. Please make sure for studying purposes you are keeping track of those. And you'll see why. It's not just an arbitrary thing. Well, hopefully you'll see why. It's not just an arbitrary thing. It is because you can kind of like with the older antihistamines and the newer antihistamines, hope you guys remember that, first generation, second generation, you can kind of make some generalizations, some stereotypes about the older agents, the typical agents, conventional agents, and then you can also make some generalizations about the newer agents, the atypical agents. So for example, the newer atypical antipsychotics are usually more effective They typically have less toxicity. I'm going to be saying typically like crazy now. They typically have less toxicity, and they're usually better tolerated than the older antipsychotics and have less permanent adverse effects, with the exception of Clozapine. So Clozaril, Clozapine. Note that in your slides and everything, and I mean, we're going to get to it, but it's atypical, but it still has some pretty bad issues with adverse effects, specifically neutropenia, which we'll be talking about here in a little bit. And so that's the one newer agent that does you still have to be worried about toxicity, and it's been pulled from some markets. I believe in some European countries, it's been pulled, and anyways, but in general, the older agents, the typical agents, are less effective and have more adverse effects to be concerned with. And then the other thing to think about too, and it mentions it here, is the newer agents are more expensive. They're less likely to have generics. A lot of them have become generic now, but just in general, the older ones are generic and they are cheaper. So that is why you still see them around, and they have some little niche uses, and some of the older ones are more popular than others, and we'll get into the details there. So here's a breakdown here. One way to organize it, I'm going to organize it a little bit differently. Definitely for studying purposes, make sure you know these categories, but then also make sure you know any other categories I mentioned. And like I said, conventional versus atypical, typical versus atypical, newer versus old. Definitely make sure you're keeping that straight. So let's just jump into it as far as the specifics for antipsychotics. FDA warnings. So this is, again, no surprise here. Definitely make sure you study this for my exam. So starting about 2003, there were risks that were labeling for risk for all of the newer antipsychotics, the atypical antipsychotics, for increased risk of hyperglycemia and diabetes. In 2005, they increased that to a box warning. I'm sorry, they didn't increase that. They kept that. That was just a regular labeling. But then in 2005, they added, a box warning for all atypical antipsychotics. They increased the risk of death in patients treated with certain atypical antipsychotic for dementia-related behavioral disorders. So take-home point, what does that mean? In your elderly population, you basically have an increased risk of death with these antipsychotics. 2008, they decided it was all antipsychotics. So now, as of now, so for testing purposes, please study, and you'll see this on my slides, all antipsychotics have a boxed warning for increased risk in death in elderly patients. And again, the wording's better. It's more elegant wording the FDA has, but that's going to be the take-home point. So please, and I gave the history lesson here. Don't stress about the dates and stuff. You have to remember. And then in 2017, there was an additional warning by the FDA added that antipsychotic drugs may cause falls, fractures, and results of somnolence, postural hypotension, and motor and sensory instability. So it makes them even more dangerous for your elderly population, for your geriatric population. So increased risk of death for the geriatric population, increased risk of fall for geriatric population. And again, this is all antipsychotics. And then for all antipsychotics, increased risk of, just for the atypical antipsychotics, so just for the newer ones, increased risk of hyperglycemia and diabetes and weight gain. So weight gain's not on there, but weight gain, hyperglycemia, and diabetes for all of the atypical antipsychotics. And that is just a warning there on that. So a lot going on in this slide. Hopefully it was clear, my little story and history lesson and stuff. For studying purposes, just make sure you know the box warnings for all of the antipsychotics that I mentioned, the new warning from 2017 about falls and fractures, and then the older warning for all of the new atypical antipsychotics for increased risk, hyperglycemia, type 2 diabetes, weight gain. So hopefully that's clear for everybody. Kinetics, not a huge deal. Don't stress too much about it. However, it will involve the way you're administering these medications. So, for example, they do have long-acting injectables, which we have a chart coming up here that definitely want you guys to look at and pay attention to. And the take-home point really is for compliance issues. There are reasons, and you'll see this on your psych rotations, and depending on where you end up working, there are compelling reasons sometimes to give a long-acting antipsychotic. So some last, up to a month, every 2 weeks, etc. Some are longer than that, and again, it's on that table. I'd encourage you guys to read through that. But they're usually an intramuscular, so an injectable, basically it's a depot or deposit that releases the drug slowly over a set period of time. So 2 weeks, 4 weeks, longer than that, depending on the preparation. And so that's where the kinetics are relevant. So you don't necessarily have to stress about the kinetics. I normally don't test you guys over that. However, I do want you guys to know that those different products are out there. So here's a great table here. Dosages and administration of long-acting injectable antipsychotics for schizophrenia in adults. Great as far as the products that are available. So always get this question from students. I love you guys. Is this on the test? Do I need to memorize this? Do I need to study it? And I get it. I was a student too. That was always my number one question. So I want you guys to definitely read through this table, and I want you guys to know, that there is an aripiprazole extended release, that they do make these different injectables and stuff. However, I will not be testing you explicitly on those preparations. So definitely have to know the drug names. You have to know what class they are. You have to know what they're used for. But as far as all these specific preparations and specific trade names, etc., I'm not going to pull test questions on there from there. I also won't pull test questions from the dosage as usual. But like I said, I do feel like there's a lot of good stuff going on here. And I do think it would be good for you guys to at least read through it once. It will help for your rotations, and it will help for your board exams. And then I just did this because it drives me crazy. I can't read, my vision's not good enough, or this too small print or whatever, but just wanted to zoom in and so make sure you guys are seeing what I was talking about as far as make sure you know these drug names, and you are studying them and you're categorizing them appropriately. You know the side effects, and you know what they're used for. And these obviously are all antipsychotics for schizophrenia. But, when you're on your rotations, I think that there's an Invega Trinza. It'd be good to, to have at least read that one time, at least have a little bit of experience with it. The other thing to note too, these ones with the asterisks on the name, they are not available in the US, so obviously don't worry about those for testing purposes. Well, I shouldn't say obviously, but sorry for, I'm trying to sound condescending or anything, but I will not test you guys on the Canadian drugs. And I was about to do a Canadian accent and I can't, so I'll spare you guys that too. But so don't stress about those drugs. And if you don't see them in other places in my notes, it's because they are Canadian drugs. So yeah, just read through it. Like Abilify Maintaina, it'd be good if you knew that that exists, but, again, for my exam, that is not something that I will be testing you guys on. So hopefully that helps. And with a lot of this presentation, it's jam-packed. There's a ton of stuff going on. Just always email me if you're not sure about what I said as far as studying, etc. Okay, so now just an overview here with the antipsychotics mechanism of action, MOA. We will be listing, and you guys are responsible to go through and study the mechanism of actions for all the ones I've listed. But just in general, I felt like this slide helps in the sense that when you're talking about antipsychotics, you need to be thinking about dopamine and you need to be thinking about serotonin. Basically, it's kind of take-home point. There's going to be some specifics, like I said, with the specific drugs. But take-home point, you're altering the dopamine pathways and you're having an effect on serotonin. That's really the take-home point. And you're hitting some different dopamine receptors and different serotonin receptors. It's going to depend. We'll see the subtypes coming up here. But so you have your D2, D3, those are dopamine receptors, and then your serotonin, the different numbers as well. This one too, this one can maybe help with as far as studying for mechanism of action. You don't have to explicitly memorize it, but it is good. It's kind of a good review too. Like you block the histamine receptors, you get sedation, and we talked about that, with the older antihistamine drugs. Muscarinic receptors, you have anticholinergic effects. Serotonin receptors, you have antipsychotic. Blocks the antipsychotic effects. Alpha-adrenergic receptors, hypotension, failure to ejaculate. Dopamine receptors, antipsychotic, extrapyramidal, and endocrine effects. So you'll be seeing these blockades later in some of these mechanisms of action. So this table may help you for studying purposes, but don't necessarily stress about memorizing it verbatim for my exam. Antipsychotic uses, so a lot of different things that can be used for. Mainly, though, and the reason we're talking about it, and it's in the name, they are used for psychosis, specifically schizophrenia and mania. Some of them can also have antiemetic properties, so it can be used for nausea and vomiting. Have a list there, and we'll have some more uses later, so please pay attention to those. And then they sometimes have some kind of weird off-label uses. So, for example, if someone has intractable hiccups, one of these older antipsychotics, doing these typical antipsychotics, could maybe be beneficial. And usually those are off-label uses, which we'll get into here in a little bit. Antipsychotic adverse effects. This is going to be very important. I know the slide doesn't seem like it because there's like nothing going on in this, but for testing purposes, please, 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 guaranteed going to be exam questions on the adverse effects of the antipsychotics and the older antipsychotics versus newer antipsychotics. Adverse effects is a big player with these drugs. And you noticed, I mean, we already talked about the box warnings. We already kind of highlighted those. So they involve the box warnings. They involve patient compliance, etc. They involve all of that good stuff. So please make sure you don't necessarily have to put a star on this slide. But the other thing I want to note too is that they have no abuse potential. So that's the textbook kind of response. However, I have seen and heard of people abusing antipsychotics, especially the newer ones, especially the ones that cause sedation, which are older and newer. And so, for example, when I worked in Oklahoma, there was a problem with one of the pharmacies where Zyprexa, which is a newer antipsychotic, was getting stolen and apparently was being used by meth addicts, so because it would help them go to sleep. So yes, technically no abuse potential maybe from the manufacturer, but it is something, and like I've said before, you've heard in some of my other lectures, I've stopped getting surprised at what people abuse and what they either get high off of or they get down from their high maybe. So like I said, the Zyprexa makes them go to sleep after you do meth for a few days, apparently. I've been told. I don't have personal experience with that, but yeah, so that was an issue we had at one of the pharmacies up in Oklahoma when I worked up there. But anyway, so yeah, just kind of take that with a grain of salt. And like I said too, you'll probably notice throughout your practice that humans are very creative and very resourceful when it comes to mind-altering effects, is the most political way, kind of the nicest way I can say it. In other words, people are really good at getting high. So yeah, just a heads up on that. I mean, I wouldn't stress too much about it, depending on your... It's just really going to depend on your patient, and if you suspect that they're diverting. If they keep losing their prescription every 3 days and they want, quantity 90 or something, maybe a red flag with some of these newer antipsychotics. More adverse effects here. So we have neurological effects just in general, and we'll list some more here later on. Oh, no, and these will be on a table later on, but yeah, so these are going to be for all the antipsychotics. And like I said, there's going to be a table here that's going to break it down as far as the specifics. So I think this is the best way to cover it, but I don't know. As you always, just let me know with feedback and stuff if what you guys think for the next year. But neurological effects in general, like I mentioned, the CNS depression, but some of those neurological effects are desired. So it's kind of hesitant when I talk about the neurological effects because it's going to really depend on the patient and what specific psychotic event you're trying to treat or what specific type of psychosis they have. So anyways, movement disorders. This is an issue, especially with the older older antipsychotics. So extrapyramidal effects and iatrogenic Parkinsonism. So basically, the person has dystonic reactions and akathisia. Again, there's types of movement disorders I believe you'll be learning about more in detail in ICM. But if not, I'd encourage you guys to go on YouTube and look up videos and stuff of these. They have really interesting video presentations of these. But the basic, in general, they're called movement disorders. This extrapyramidal symptoms is sometimes abbreviated, and sometimes I say EPS. So just note that may be what they are talking about there. And so please know that the way to treat that, especially acutely, is with a first-generation antihistamine, so diphenhydramine, and then a Parkinson's drug, benztropine, which is generic for Cogentin. And those two will help with the EPS, or extrapyramidal symptoms. And so, for example, in the psych hospital, or the way I always remember it, is we would send... So Haldol is an older antipsychotic and has problems with these movement disorders that are listed up here in these two bullet points. And let me do something real quick. Okay, I kind of spaced that out. Just the spacing on there. I didn't want you guys to think they're lumped together. So these two bullet points here are lumped together as far as to explain the movement disorders and their treatment here. But yeah, so at the psych hospital, we would send down an intramuscular which is injectable haloperidol, and we would also send the Cogentin and the Benadryl with it. So the nurses would give the Cogentin with the Haldol, two brand names there, but benztropine with haloperidol. they would give together. So then you're giving the antipsychotic, but then you're also at the same time trying to prevent the movement disorder. And you'll notice too that it is time dependent. So these adverse effects in relation to the movement disorder with these older antipsychotics are time dependent, and they get progressively worse. You can read through that, and then they also can become permanent the longer that the person is on these older antipsychotics. So every once in a while, it's interesting. You'll see someone at the store or around town. I don't know where you guys hang out, or where you guys are going, but you see some person in the community where they'll have some kind of movement disorder that is kind of a signature of the older antipsychotics. So it's like, oh, maybe they were on these older antipsychotics in the 70s or something, in the 70s, 80s for a longer time, and they have these permanent movement disorder. And you'll notice here too, kind of, again, it progresses, more likely to have these symptoms in weeks versus months, years. And then the tardive dyskinesia is another type of movement disorder that can be irreversible. So I believe you guys are going to be covering this more in detail in ICM course, but if not, I'd encourage you guys to go onto YouTube and type in tardive dyskinesia or some of these other ones, this type of tremor, rabbit syndrome, etc. And you can get an interesting visual on it, and then it may help with studying purposes, or at least it helped me when I was studying in pharmacy school. And I guess if I was like a fancy, better professor, I would have had like little video clips and stuff, but sorry about that, guys. Maybe next time. Yeah, but one other thing I want to note too is that please make sure you are studying that, for this neuroleptic malignant syndrome, the unstable blood pressure can be treated using dantrolene and bromocriptine. So please note that. I will pull test questions, and there will be board questions like that. Same thing here too. The benztropine, diphenhydramine can be used to treat the EPS. And like I said, my little anecdotal story there, given at the same time as the haloperidol injection. So make sure you're looking at squinting at the details, so to speak, and looking at those little things as well. More on the adverse effects. So a decrease in seizure threshold. Some are worse than others, but definitely something you need to be cautious with, especially people who have a history of seizures, or if there are other drugs that can cause seizures, or if the person is withdrawing from certain drugs, certain medications on a drug withdrawal. Again, increased risk for seizures. So those weight gain, like I said, with all of the newer antipsychotics, so atypical antipsychotics, you have to be concerned with weight gain, but specifically the Zyprexa and Seroquel, which are brand names there, you do have to be more concerned with the weight gain, so they have more of an incidence of weight gain. And I forgot to mention this too, but you guys have probably noticed already that I am including the brand name here. And the reason why is just because I feel like a lot of these, especially these newer antipsychotics, are only referred to by their brand name, even though Seroquel is generic now, or some of these are generic now. Most people still refer to it as Seroquel, not Quetiapine. But anyway, so that's something to think about. QT prolongation, there are some newer and older ones here. And so that may be an issue, something to think about. If a person has a history of arrhythmias, if they're on other medications that can cause a QT prolongation. And then elevated serum prolactin. Great chart here. Definitely put a star here. I would definitely make sure you guys are studying this chart and looking at it. So we have the first generation agents up here, second generation agents down here. Then we have the different adverse effects that we need to be concerned with. So this is, and then the pluses and minuses as far as is it higher or lower. So you notice that the weight gain, usually they're more with the newer agents. And you notice the Clozapine is there, Olanzapine, some of the newer agents. Less so with some of the older agents, so like haloperidol doesn't have as much weight gain, diabetes mellitus, type 2 diabetes. Cholesterol can be an issue. The EPS TD, so that's extrapyramidal symptoms, and then tardive dyskinesia, so those are the movement disorders. You'll notice the older ones typically have some more issues with those. It's interesting though, because the longer that these newer agents are out on the market and the longer people are taking them, they are starting to see more movement disorders with them. But anyways, that'll kind of just depend on what happens later on. Prolactin level elevation is there. This is kind of a mixed bag, more so with an older agent. Sedation is there. Again, maybe more with old agents. And that actually, the sedation can be one of the reasons why these are prescribed. So I know the haloperidol was given sometimes for the sedation, so that may be something that they're looking for. Anticholinergic adverse effects, definitely note there. Notice it's worse with some of the older ones, maybe than some of the newer ones. Orthostatic hypotension is there. Also, please note that the FDA put that warning in 2017 about fall and fracture risk with elderly population. And then QT prolongation. So great summary here. Definitely make sure you're studying this, looking at this. And these are going to be the big adverse effects that you're going to want to be concerned with the antipsychotics. And you can, like I was saying too, hopefully you guys can start kind of making some generalizations with the second generation versus the first generation. And like I said, in general, second generation has less adverse effects and is better tolerated, with the exception of Clozapine. So you notice Clozapine still lights up the adverse effects here and still has some issues with adverse effects. All right, now we're going to get into the specifics here, specific drugs. This is going to be kind of quick, but there's a lot of information going on. I just wanted, for completeness sake, I added all of these new slides to make sure everyone had a complete picture, because historically I did not list all these drugs, and the student feedback was that they wanted them all listed. So here we go, let's get into it. First off, we're going to start out with the first generation, which are called the typical antipsychotics. First, we have Chlorpromazine, older one. Definitely read through the mechanism of action and make sure you're looking at that. The uses here, big list of uses here. We talked about the hiccups earlier. Oops. But make sure you're looking through these uses. I definitely want you guys to know which ones are used for what. And especially with some of these older ones, they have kind of unique uses, and there's not things that you necessarily think about, like, you know, tetanus, maybe hiccups. That's not stuff, but so anyway, so yeah, please make sure you are going through all of those. Contraindications, as always, please make sure you're studying these. Basically, it's just related to the CNS depression. And then box warning, increased mortality in elderly patients with dementia-related psychosis. So that was that box warning I said that the FDA has added to all antipsychotics, old and new. So you will be seeing this repeated throughout the presentation. Later on, though, I'll just have this top little part, increased mortality, and in the bold, and I won't put all this stuff every time. But just so you know, it's for all of the antipsychotics. Chlorpromazine, again, another one that can be used antiemetic. It's also another first-generation antipsychotic. It's interesting, though, it's only going to be used for nausea vomiting. So you could, for studying purposes, or when you're thinking about this mentally for your board exam, you could only have this as in the GI module, but it was first developed as an antipsychotic, but nowadays it's only used for nausea vomiting. Contraindications, make sure you read through those. And then the box warnings. This one's interesting. It's a little bit different. It has the dementia only box warning. And part of the reason that it's not like the other antipsychotics is because you'll note the use is it's not being used for psychosis. So the FDA allowed this one to not have the specific blanket one, but it still involves elderly patients with dementia-related psychosis. They are still an increased risk of death. So take-home point with this box warning is that the elderly patients should not be prescribed this for nausea and vomiting. So anyway, so that's why it looks a little bit different as far as its labeling. By the way, I just copy and paste these from these box warnings. So it's not, I'm not the one going through and like making the wording and stuff for this one. For some reason, this one was a little bit different. But take-home point's kind of the same too. Antipsychotics can increase risk of death in elderly patients. Thioridazine, this one, another first-generation antipsychotic. Please read through the mechanism of action. It's used schizophrenia, but again, it's an older agent, so it's probably not going to be first line, and you need to be mindful of your adverse effects. Contraindications related to the CNS depression. You also be mindful of and be careful with the increased risk of QT interval, so long QT syndrome. So, and these will all be reflected, by the way, back. I'm going to jump back here. This is all going to be reflected back over here on this chart. So you'll notice the QT prolongation there is highlighted. So that's why I keep kind of going back to this chart. Or for me, studying and then also for writing the exam, it was a good place for me to go because it was like, what does this one do? And who is this? Where is this? Where does this fit? So hopefully this table will help you guys for studying. But anyways, where was I? Yeah, uses schizophrenia, contraindications, and then box warnings, again, related to the QT prolongation. It has pro-arrhythmic effects, so it can cause arrhythmias, and then it also has the increased risk of killing old people. So please make sure you're studying those. Fluphenazine, another older atypical. mechanism of action, please read through that. Used for psychiatric disorders, psychotic disorders. So some limitations of use. Some of these have that, some don't. Just make sure you off-label uses, some movement disorders, and contraindications. CNS depressions there. Some blood issues, and then it only has the one box warning for the increased mortality in elderly patients. Fluphenazine, another first-generation antipsychotic. This one can use for non-psychotic anxiety, but short-term generally is a non-psychotic anxiety, but this is not considered first line, but it is there. It can also be used for schizophrenia, and then the off-label for psychosis agitation associated with dementia. Contraindications, please read through those, and then the box warning is the same, increased mortality in elderly patients. Loxapine, another older antipsychotic, can be used for schizophrenia, also used with schizophrenia or, agitation associated with the schizophrenia, so acutely for the agitation, and or bipolar 1 disorder. One thing to note too, they do make an inhalation product, but there are risk of bronchospasms with the inhalation product, and so you have to be a specific facility has to enroll and go through paperwork and kind of sign up to do that. So I don't know. They didn't use it at the psych hospital I was at in San Antonio, but it'll be interesting to see what you guys find out and kind of see on rotations and stuff. Contraindications. So by mouth, it has some contraindications, and then again, inhaled, you do have to be concerned with bronchospasm. So it's related to the contraindication, but it's also related to a box warning. So, and it's specifically only for the inhaled product. So please note that when you're studying. And then any form of the product has an increased risk of mortality in elderly patients. Perphenazine, this one can be used for nausea, vomiting, older antipsychotic, and also used for schizophrenia. So this one, I've actually I've dispensed this one for both. So, and it was probably because I was at the psych hospital. But anyway, so, and then it also can be too, if a person has schizophrenia and they have nausea and vomiting, this may be a good choice to use. So I would see that in the psych hospital. A person had some upset stomach. They already had some kind of schizophrenia or some other diagnosis that warranted this use of the antipsychotic. So contraindications, you'll notice the CNS depressions there again, kind of bone marrow suppression, blood dyscrasia, liver damage. Those are a little bit different on there. So please make sure you are looking at the differences of the contraindications. And then the box warning, increased mortality. So we've seen that before. Thiothixene, another older first generation, used for schizophrenia, contraindications there, CNS depression, again, just things that are coming up over and over again. And then box warning is the same as we've seen with all antipsychotics. Pimozide, another older antipsychotic. I don't think I've ever dispensed this one. I was looking at this one, I was like, have I ever seen this in real life? IRL? I don't think I've ever seen this one in real life. But and probably because of its use, it only has the FDA approved use for Tourette disorder. So I'm not saying that I've maybe never filled prescriptions for someone who has Tourette's, but yeah, I don't even remember the psych hospital. So anyway, so this one's kind of a head scratcher. I don't know if you guys are going to see it or not, or be prescribing it, but it's interesting. Contraindications, lots of contraindications here. Probably part of the reason it's not used a lot. You have to be concerned about QT prolongation, CNS depression, some drug interactions. So it's kind of a messy drug. But I know with Tourette disorder, that can be a hard disease or disorder to treat. And so it may be warranted then. And probably the reason it only has the one FDA approval is because of its kind of a messy drug. And that's just all speculation, by the way. And then where didn't I put the... Oh yeah, and then this one doesn't have the box warning. Let me double check that real quick. Oh yeah, okay, here we go. Here's up to date. They don't have the box warning listed. So I remember this now that I'm looking it up and thinking out loud. It's because it's not used for psychosis. It only has the labeled use, only FDA use for the Tourette's disorder, and so it's not, shouldn't be used for psychosis in elderly patients anyways. So anyways, it only has the Tourette's disorder. Risperidone, another antiemetic, old antipsychotic, so it can be used for nausea, vomiting. And this one too, niche use, just post-op nausea, vomiting. Maybe used for agitation, just kind of depend. But and this is another one too. I've only dispensed this one or seen this one being used as an antiemetic. But you know, I mean, who knows? The world is a big place. I don't know what you guys are gonna see when you get out there. But so anyway, so that one, from my experience, mainly an antiemetic, but it's still typically, I'm sorry, is typically, I keep seeing this typical. It still is technically a typical antipsychotic. Contraindications here and box warnings. This is probably another reason why I haven't really been seeing used a lot. But contraindications, please look through those. And then box warnings, arrhythmia, so increased QT prolongation. Definitely something to be concerned with this medication. Haloperidol. So this is a very popular drug. Seen this one dispensed a lot. Ad nauseum, as they say. So it was used extensively in the psychiatric hospital. It's also used in other hospitals as well. For your psychiatric patients. And again, it's really just going to depend on the facility, meaning what specific hospital you're at. You're at Mission Hospital, you're at Rio Grande Regional. You guys are going to be all over the valley on your rotation. So it'll kind of depend a little bit on the hospital. Definitely if you guys do psych rotations, I'm thinking you'll be seeing, I sometimes, I'm like, I guarantee you're going to see it, but then every once in a while, this student comes back to me like, I never saw, you said I was going to see this and I never saw. So, you know, come on, my prediction rate isn't great. But I would think there's like a 90 something % chance that you will see haloperidol, which is generic for Haldol, being used for your psych patients out on rotations. So it's an older drug, but it's interesting, but it still is used a lot. So, and to me, again, my experience in the psych hospital, this was the most used older antipsychotic. So we dispensed a ton of the new antipsychotics, and then we also dispensed a ton of haloperidol. So those were those like top first generation antipsychotic that we dispensed in San Antonio Psychiatric Hospital. So again, you know, I can't say what you're going to see at the hospitals in South Texas or deep South Texas, Rio Grande Valley. But for us, it was haloperidol. And the other thing too is I know with my wife, she's in a local hospital here in town, and they use it a lot for agitation and stuff on the floor in the ICU. Just, you know, because you get psychiatric patients in that will, you know, break a leg or something, or they need to be in the hospital for other reasons, or they have, we talked about hyperglycemia, they have type 2 diabetes, or they have high cholesterol, or they have other heart issues, etc. So that's part of the reason I think too you'll see this used, because they make it injectable, we talked about, and it's on that chart, and it's just kind of a quick way to give an antipsychotic to help with something like agitation. So if a patient is having trouble staying in their bed or wandering around or whatever, this could be something that can be used for that. So note on there are a lot of different uses. So it has a tablet, which is by mouth, and the concentrate, which is the injectable. Behavioral disorders. So this is a big reason why it will be used, especially PRN, pro re nata, or as needed, as they say in English. So as needed for behavioral disorders. So definitely something that I think you'll be using or seeing it for. Psychotic disorders, schizophrenia, Tourette's disorder too, and then hyperactivity. So this is short term. It's a little bit controversial depending on what physician you talk to and who you talk to. But again, the psych hospital that I worked at, we had kids as young as like 4, 5, 6, all the way up until, 99-year-old patients or whatever. So the facility I was at had pediatric sections, units, and adult units. And it had a military unit, and it had a drug rehab unit. It was interesting. It had a really interesting mix of things there going on. But anyways, so it would sometimes be used for hyperactivity short term, so acutely for hyperactive children. As far as, again, my experience in the psych hospital, it was for those children that had maybe other diagnoses on board. So it wasn't just your, like, oh, this kid has a lot of energy, kind of. It was, there were usually other things going on with it. But anyways, so yeah, I had some students ask me about that. They're like, what, hyperactive, so, and then off-label uses, please make sure you read through those. It can help with emesis. So you may see it there. Delirium in the ICU, that's what I was saying, my wife will prescribe it a lot when she's on call overnight for the ICU patients that have delirium. I'm just laughing. I'm not laughing at the patients who have delirium. I'm just laughing because my wife was just on call the other night, and she was tired this morning, and She's just like so sick of it. She's like, I can't. She's counting down. She only has a few more. She's done in June, so she has a few more days left. But anyways, I don't know when you guys are gonna be listening to this, but yeah. So that's why she's just like, no more ICU. She doesn't want to be in the ICU anymore. Anyways, OCD can be used for OCD, post-op nausea, vomiting, prevention. And the rapid tranquilization, so agitation, aggression, violent behavior. That's what I was saying, that they'll use that IM injection, intramuscular injection, and just get the patient to rapidly calm down, especially if they're being aggressive or violent. Contraindications, so please make sure you read through those. You don't put Parkinson's disease on there because this is an older antipsychotic. It does have an increased risk of the movement disorders, and like I said, it is then given a lot of times with the cogentin, which is benztropine, and or the older antihistamine, which is going to be your Benadryl, your diphenhydramine. So please make sure you note that and study that. Same box warning, increased risk of death for elderly patients. Now we're changing gears here. So that was the last. If you want to draw a line on your notes or whatever, put a big red line in the bottom of this. That is the last older antipsychotic. From now on, we'll be talking about the second generation, the atypical antipsychotics. First off, we have Risperidone, generic for Risperidol. Notice it involves the dopamine and serotonin pathways. So make sure you're reading through that. Uses. So I have it broken down here by injection versus oral. It's a little bit different, but you don't have to necessarily memorize that. I'm not going to ask you, which of the following is an injection-only use for Risperidone, but just study them all together. Make sure you know all of the uses. I mean, they overlap. So schizophrenia is on both, and bipolar is on both. But anyways, so just make sure you're looking at those. Contraindications, hypersensitivity is there, and then the box warning. So you can notice they are usually have less contraindications and again usually better tolerated. Paliperidone, another second generation antipsychotic. Please read through the mechanism of action. Notice the serotonin and dopamine involved there. Can be beneficial with schizophrenia, schizophrenic disorder. Contraindications, we have hypersensitivity, and then the box warning is the one we have been seeing. Haloperidone, second generation, atypical antipsychotic, again involving serotonin and dopamine. Can be used for schizophrenia. Contraindications, not too bad, just the hypersensitivity there. And the box warning is the same. So you'll notice here again, kind of making some generalizations, making some patterns here. Hopefully you'll start noticing that these newer agents have less contraindications, less box warnings, with the exception, again, all antipsychotics, anything that's used for psychotics, psychosis is going to have this box warning, but usually better tolerated. Lurasidone, another second generation antipsychotic. Again, mechanism of action, you're going to start noticing a pattern here. This one hits the histamine receptors as well and does not hit the histamine and muscarinic receptors, hitting those serotonin and dopamine. Uses, bipolar disorder, schizophrenia, off-label uses. I don't have this extra dot here. You guys can just delete that. Contraindications. So this one is a little bit different in that you do need to be concerned with drug interactions with this one. So please note that when studying for this medication. And then as far as its box warning, it has the one we've seen before about elderly patients, but it also has an additional one for increased risk of suicidal thoughts and behavior in pediatric and young adult patients. So that is something to be mindful of. The other thing to note too is that this second box warning is one of those that the FDA requires for all antidepressant medications. So any medication has an FDA approval for depression has to have this increased risk of suicide thoughts and behaviors in pediatric and young adult patients. So the reason that this one has it, even though I am classifying it as a second generation antipsychotic, it does have an FDA approval for bipolar depression. So theoretically, there could be a 15-year-old who has bipolar disorder and is on lithium and has been given this in combination with the lithium for their depression, bipolar depression. That is why we have this suicidal thoughts and behavior. So for that patient that I just mentioned, that hypothetical patient, they need to be closely monitored and making sure that their depression is not getting worse, their suicidal ideation is not getting worse, and that they they aren't having suicidal behaviors, suicidal thoughts, etc. And then, especially with the pediatric patients, that their caregivers and the other adults around them are mindful and aware of the increased risk of suicidal thoughts and behaviors. So that's why that's on that one. It was kind of like before we saw that if it has an FDA approval for psychosis, it's going to have this, but some of those older antipsychotics who didn't have the FDA approval for that. So same thing's going on here. And please make sure when you're studying the antidepressants, you add this box warning, to all of the antidepressants. Risperidone, another second generation antipsychotic, hitting those dopamine and serotonin receptors. Use, we have schizophrenia, bipolar disorder, an adjunct to bipolar disorder, acute agitation, and then some off-label uses. Contraindications, this is the one that you do need to be careful with: increased QT prolongation. So it doesn't have the box warning that it's pro-arrhythmic. However, you still need to be careful with arrhythmias with Risperidone. So please make sure you note that when studying. Clozapine. So like I said, this is going to be the newer medication, the second generation atypical antipsychotic that is still more dangerous, and it is less well tolerated, does have more adverse effects, and it is one that is newer, but it still can be pretty messy drug. It can be used for schizophrenia that is treatment resistant, so this typically is not first line, and I'll get into the reasons why, but this is usually the ones that, they're not responding to any other antipsychotic. And then suicidal behavioral schizophrenia, schizophrenic disorder, again, usually not first line. And then off-label, treatment-resistant bipolar, treatment-resistant psychosis. So you'll notice here there's a pattern here. This is going to be your last line. And the reason is because of the box warnings here. So contraindications, please make sure you read through those as well. But this is the big reason why this is not considered first line. So you notice an increased risk of orthostatic hypotension, seizures, myocarditis, some heart issues, and then increased mortality. But the big one here, and put a big star by here, it's rare but fatal, severe neutropenia. So because of this, you have to register with special registry, and so it is only available through restricted programs. So the pharmacy and the practitioner and the prescriber. So, and I believe PAs nurse practitioners can sign up for this as well. They have to go through a special sign-up program to get registered, and the patient has to have their ANC monitored to make sure that they're not developing neutropenia. So they have to have an absolute neutrophil count, which is ANC. And that we have to have documentation in the pharmacy before we can dispense the medication. The provider has to request documentation, the labs have to be drawn, etc. So, because the neutropenia can be fatal. So I'll take you guys on a quick little field trip. So here you go. Here is the website that you guys will have to go through if you are interested in, and really it probably would only be if you are working as in a psych facility or with a lot of psych patients, because I'm going to say the only time, well, no, I'm not saying only. I've dispensed this a couple times when I didn't work in the psych hospital, but I worked in Texas Tropical in the Valley, and then the psych hospital in Laurel Ridge in San Antonio. And those two pharmacies were the ones that I dispensed the most Clozapine in. Every once in a while, another, like when I worked at Fry's Pharmacy in San Benito, there was like one patient maybe that had Clozapine, maybe, but it was a lot less common. So as far as you guys signing up and stuff, it just will kind of depend. But so it's Clozapine REMS, and the REMS is that, excuse me, it's right here, is the risk evaluation and mitigation strategy. It's there in your notes. So the catchphrase is, and what we see in the pharmacy is, no blood, no drugs. So basically, if you don't have a lab, we're not going to give the drug out. So that's where that's little, and it's nice now. So back in the day, before you guys were in PA school, there used to be like 2 or 3 websites for this, and they luckily have streamlined it. They only have one, clozapinerems.com, to use, and you have to get these certifications. So I had to, and it's probably changed now. I'm probably out of date, but I'll probably have to re-sign up if I go back to a psych pharmacy. So start pharmacy certification here, or start prescriber certification here. And then there is the update as of 2016. And it just says, what is a Clozapine REMS program? So it's associated with severe neutropenia, which you guys just learned about. So requirements to prescribe, dispense, and receive Clozapine are incorporated into a single shared program called this website. So this is supposed to keep track of the patient, and no matter what physician they go to, and no matter what pharmacy they fill out, this website or this agency will notify you. So it was really interesting in the psych hospital in San Antonio, because we'd get patients from all over. Well, we had military patients too, so they're from overseas or where, I mean, military people are all over the place or different states and stuff. And then San Antonio's pretty good sized city, pretty big city, and it has good mix of people from out of town and stuff. So we'd get people from out of town. We'd look them up in the Clozapine registry, and then we'd see like, oh, their last lab in California or something was this or whatever. So yeah, the idea is just to prevent the severe neutropenia. And like I believe I'd mentioned before, the neutropenia and some of these box warnings is why this medication is not available in some countries. So some countries just completely pulled it. The US initially pulled it, and then they put it back on, but with all these restrictions and stuff, because it is something that, and this comes from the psychiatrists, again, at the psych hospital, have said it is, sometimes it's the only thing that works. You'll notice this treatment resistant. So if you see a patient on this, it's probably because they have to be on it and because nothing else was working for them for their schizophrenia. So anyways, that's the end of that. So hopefully that's all. But please make sure, for studying purposes, put a big star here, that you know that Clozapine is different when it comes to the atypicals. Olanzapine, another second-generation atypical antipsychotic, another one that's hitting the dopamine and serotonin pathways. Its uses is going to depend on if it's by mouth, if it's extended release injection or short-acting injection. Please read through all those. And then you'll notice it has some other uses. This is a newer off-label use. It can be used for nausea and vomiting with chemotherapy associated acute and delayed nausea and vomiting. So that's interesting, but just read through those. Contraindications. Interesting in that there technically are no contraindications that are listed in the manufacturer's labeling. But in pharmacy school, we were taught, and I try to encourage you guys, that all medications, no matter what, if a person has a hypersensitivity to it and a true type 1 hypersensitivity reaction, that they should not be taking this medication, so that technically all drugs have a contraindication. So if you want to put that, I mean, I won't test you guys over little things like that, but as far as like trying to trick you or whatever. Box warnings has the one we've seen before, increased mortality in elderly patients. It also has post-injection delirium sedation for specifically this extended release intramuscular formulation here. So that's the brand name there. Zyprexa Relprev with 2 V's. I don't know why it has 2 V's. It's not a typo. I guess Relprev with 1 V was probably already trademarked or copyrighted or something. So Zyprexa Relprev. And I don't know if you keep saying, I don't know if you're supposed to pronounce both of these, or I don't know. The drug reps will know. You can talk to those people. But this specifically has a box warning for that. So yeah, and because of that too, it is only available through restricted distribution program. So make sure you read through that. Quetiapine, another atypical antipsychotic, mechanism of action, another one that's hitting the serotonin and dopamine. This one can be used for bipolar disorder, major depressive disorder. Only the extended release tablet got that labeling for MDD. And then for schizophrenia, off-label uses there. Please read through those. The contraindications there, not too bad, just hypersensitivity. And then box warnings, you'll notice, because it has FDA approval for being an antidepressant, we have the suicidal thoughts, increased risk of suicidal thoughts and behavior, box warning, and increased risk of mortality in elderly patients. Asenapine, second-generation atypical antipsychotics, can be used on the serotonin and dopamine receptors, used for bipolar and schizophrenia. Contraindications, does have some hepatic impairment warnings there. So of these, this is the one you have to be concerned with. And then the box warning we have seen before. Cariprazine, newer antipsychotic. Mechanism of action, please read through that. To be used for schizophrenia, bipolar disorder. Contraindications, just hypersensitivity, and then the box warning, which we have seen before. Aripiprazole, another second-generation antipsychotic. Mechanism of action, it looks similar as far as what it's hitting, its receptors. This one has some different uses on it that you guys can read through. It also has the oral versus injection uses. Contraindications, not too bad there. And you'll notice the box warnings are there for the all antidepressants and all antipsychotics. And this is because it has the labeled use for depression. Risperidone, second generation antipsychotic. Mechanism of action there, it's hitting the serotonin and dopamine receptors. Major depressive disorder, schizophrenia. And because of depression and schizophrenia, we have both of the box warnings. This is another newer one too. Pimavanserin, another second generation, newer antipsychotic, serotonin and dopamine receptor hits. Parkinson's disease psychosis is the only FDA approved use for it, which is interesting, and it'll be interesting to see if they use it for other things. Let me fix this slide real quick. Sorry, just a little typo there. I just got rid of that. And you guys will get the newest slides, so your slides won't have that. Contraindications, hypersensitivity, and then because it involves psychosis, it does have the increased mortality in elderly patients. Here's a summary table. You can go and read through this. A lot of the newer antipsychotics, the newer atypicals are not listed on this table, but please still study them for my exam. But you can go and read through this chart too. The red line here is supposed to denote the older ones, the typical / conventional, and then the atypical / newer antipsychotics. Great table here, and let me zoom in on it. Okay, I just got it on up to date because it's easier to see. And why is it? Okay, that's easier to see. So please make sure you are studying this. It has the first generation antipsychotics. It has the agent, which I, of course, want you guys to know. Dosages. You guys can just read through this. You don't have to worry about it. Formulations as well. You don't have to necessarily memorize the formulation that comes in. Half-life. You do not need to memorize. The metabolism. Don't stress about the metabolism and the enzymes inhibited unless I noted to worry about the drug interactions. And then the notes here are an important column. I would read through those and make sure you are looking at the notes on that. So we have the first generation, second generation, and some good little pearls here and some little notes for you guys to look through. And then the fine print too is always good to look at. So that is where I'm going to stop for that presentation. So that is going to be the last slide for part 1 of the Psychotherapeutics lecture. So thank you guys for your time and attention. Next time, part 2, we will pick it up on the antidepressants slide. Please feel free to email me if you have any questions, comments, feedback. Thank you guys again. Talk to you later.